Okay. Right. Welcome to the second session, and my sincere thanks to Professor Paul Giangrande for his presentation and also answering most of the questions. So I think the panel discussion will be easier. So now we'll go to the case presentation. We have three cases. Dr. Amar Lal will present two of the cases. Amar Lal is a very prolific case presenter and speaker. He is a hematologist consultant at Toam Hospital and also oncologist. And he always has got many cases up his sleeves. I don't know how he managed to get them, but he does. He is well known to all of us here in the UAE for his prolific case presentation. And usually he has very interesting cases and a special way of presentation, which nobody else has. Amar Lal, please welcome.
So, good evening, ladies and gentlemen. Thank you, Dr. Marashi. Nice introduction and inviting me to present some cases, our local experience. This is a disclosure. So, I will start that I have nothing new to tell you here. Hemophilia is as old as the hills. I will start with the one code by Mr. Philip. As he said, I will do some, step one is retainer by some stimulator by eye opener. I will take you some reminder by play quiz test, and then refresher, treatment algorithm, real world practice, and finally finisher, which will take home. So just eye opener, what color is the ribbon for bleeding disorder awareness? Dr. Paul will answer the question. Okay. When is Hemophilia World Day is observed? It is March and April. March is actually rare bleeding disorder and April is hemophilia. Okay. So this is why we are talking acquired hemophilia today, because Dr. Paul is with us, so that's why we are talking. Is it right? So actually, the idea is to understand the rare bleeding disorder, especially acquired hemophilia, and explore the barrier which we face in challenging, and to make it correct diagnosis in time, referral, and investigation, and treat it accordingly. So this is the objective. Now I will go ABC. A, assess burden of the disease, who at risk of the bleeding disorder. Here you can see from 5 to 50%, everybody in every subspecialty, they see the bleeding disorder. And B, basic hemostasis. Hemostasis is two-part, primary and secondary. Primary is include like vasoconstriction and platelet plug. And secondary is, cascade of coagulation. So this is for just a refresher. And C is challenging our cause of bleeding. We know. First is the acquired hemophilia A and B, and then you can see acquired hemophilia, then von Willebrand disease, and all these things. So now, again, there is 2 minutes more to make it more stimulus, some quiz-based. 18-year-old male who has never presented to physician, bleeding in which following anatomical location and hemostasis is defected in primary hemostasis. So it is joint bleeding in primary hemostasis. As Dr. Paul has mentioned, secondary hemostasis is affected mucosal bleeding. So this is the difference between acquired and congenital hemophilia. And second thing is the male who's diagnosed hemophilia, so percentage of factor is less than 1%. So how would you label this? This is again just for, severe. You should know, severe, mild, and moderate. This is for especially non-hematologists I just wanted to put. The last one is stimulus is 74-year male who has lymphoma in the background. And he underwent also some surgery and he bleed profusely. So he was called, Dr. Marashi was called, he was on consultation. And Dr. Marashi reviewed, patient is not any blood thinner. He just found he has isolated APTT high. So what he did, he will do inhibitor to factor VIII level. So with this, you have seen it is all It is all, hemophilia treatment center. We have all these things. So if we miss anything, we'll be in trouble. So the solution is you need a team care. Everybody should be there like this. So in now next 10 minutes, I will present my 2 cases, how I treat in real world experience. So this is my first case. It's about 3 years ago. This is 73-year gentleman who has multiple comorbidity, diabetes, hypertension. Actually, again, acquired hemophilia is like missing diagnosis. Same journey over the 2 weeks. He was going first upper respiratory infection. He was mucus bleeding, then some rashes in the neck. Then he went to ENT because there was swelling in the neck. So everybody was picking different things. Even somebody labeled as a Ludwig angina because there was neck swelling, and he was taking different antibiotics, and eventually, he becomes sick, and he was brought to our ER. Then he becomes so sick, so we put him in the ICU. ICU, they checked simple tests, CBC and coagulation, and they found isolated APTT was high. And so other thing is, I think they cut down something anyway. So in this slide, actually you can see when he was brought, hemoglobin was only 5. And WBC and platelets count was reactive is high. So, and the first thing is here you can say APTT, which was isolated, APTT was high, is about 79. So which of the following is the most useful achieving in the diagnosis in this patient? As Professor Paul mentioned, you will not do any investigation, invasive, just do mixing tests first. Our ICU was smart. That night he himself sent actually mixing testing test for APTT. So as I mentioned, simple test, minimum test, just do mixing test. And other thing is it will make, is truly deficiency factor or something inhibitor. And so rule number 1, when you find high APTT, check for mixing test. So this is already presented. So now, first smart step is mixing test. That was done, and that was seen it was not corrected. So APTT mixing test not corrected, then inhibitor was sent. It was also seen high. I will show you. So this is the first lower slide. Here you see the inhibitor was 21. It was also high. As Dr. Paul has mentioned, don't think 21 is like low. Even you can imagine it maybe 40 or 50 like this, because so the differential diagnosis, as I mentioned, heparin, lupus, all the things in combined. So however, what is the appropriate next step to address this patient condition? So the thing is, patient is bleeding, and patient has now clear-cut acquired hemophilia. So what are the steps? You can give only factor 7, or you will give GUL. First step is give GUL. You will start to stop the bleeding and also steroid as well. So this patient was given all these things. So as already mentioned before him, that first step is stop bleeding. So I always use here R3 actually. R3 means first is recombinant factor 7, R1. R2 is ROIDs. ROIDs means steroids. And R3 is rituximab, to blast the B cell to stop the producing antibodies. So it's R cube. So it was used in this patient, and all these algorithms already presented, so that's why I go. So initial treatment is steroid, and followed by steroid and factor 7, and followed by, if you can add cyclophosphamide or rituximab, it's your choice. So in this patient, actually, we gave both, and here you can see APTT went down, and factor 8 also raised, and patient also stopped bleeding after 2 days actually. After the factor 7, we stopped immediately, but we continue steroid. The problem is inhibitor was still very high. It was not coming down. So what to do next? So next, as per guideline, you can say you can use rituximab as you mentioned in second line, but in this patient we use as a first line. So we are actually always use like R cube, as I mentioned, recumbent, ROIDs, and rituximab. So in this patient it was used, and this is the graph you can see here. All the things are now going fine, and this is the follow-up of the patient. So what we learn in this patient, there are 3 rules of medicine. Rule number 2, if you see APTT, you can check inhibitor, factor level, you should make a differential diagnosis. Rule number 3 is never forget rule number 1, and which is check for mixing test without waiting for hematologist. So if you see isolated APTT high, just to mixing test, till hematologist will come and give opinion. So this is my first case with the elderly male. Now next case is 31-year female. Again, similar history. She has after first pregnancy, first peripartum, since 3 months she is bleeding and she's going here and there using different GPs and practice. And because she had family history of diabetes and some immune disorder, everybody was thinking patient has APLA or something lupus. So eventually she was frustrated because bleeding was not stopped over the 3 months. Hemoglobin dropped to the 7, so they landed in some other countries as well. And even there, they didn't check anything. And finally, when she back here in the airport, it was directly brought it to ER, our ER, then again our ICU. And here you see, again in this case, what it comes, so she has multiple bruise and low hemoglobin, peripartum. So here is rule number 1, nothing replace good history and physical. Very clear cut, as a professor has mentioned, this is typical peripartum hemophilia as per history and physical. So in this patient, we found, again, same I mentioned, family history of immune disorder, and she was using oral contraceptive. As you know, gynae ops, they give to stop the bleeding. For 3 months, she using oral contraceptive, but she was bleeding continuously despite of this, and she has extensive bruise as well, and lost hemoglobin as well. So we know about this acquired hemophilia with the pregnancy. It often occurs first pregnancy and generally occurs 2 to 5 months. This is typical, as I mentioned in my case, which happened actually. So in initial evaluation, we found here, you can see the graph, hemoglobin went up to 4.5. So she bleed too much, she bleed despite of all these things. Platelets and WBC was high, reactive. And the APTT, again, it's a 70 plus, and this was all isolated. And then again, what you will do, without wasting time, mixing test, and mixing test was done, it was not corrected. You can see it is high still, around it is 50, and then factor 8 level less than 1%. So as already mentioned by professor that, these are the two graphs, one in younger, which I presented first case, and other is in elder group. So this is how I mentioned by William Osler, who said, listen to your patient, he's telling your diagnosis. You have noticed in both cases, actually, they're telling the diagnosis, but unfortunately, we don't have time to listen to the patient. Or you can say it's unfamiliarity. That's why also misdiagnosis. Sometimes these rare diagnoses take time. In both patients, first patient, it took about 3 weeks to make a diagnosis, landed it in ICU. And second patient, it took 3 months to came in again ICU in both patients. So again, in this patient, what is the next step? As I mentioned, in this, we use, actually, she was a young patient. We was dared to give cyclophosphamide as well. So here you can see APTT down, again, factor 8 level start to increase. So, but in this patient, again, we use also R cube, as I mentioned, we use in all patients now. So in this case, what we learned, rule 2, APTT, mixing test, inhibitor, factor level, as we mentioned before. Rule number 3 is never forget rule number 1. In this case, nothing replaces a good history and physical examination. So in the last 15 minutes, I have gone through retainer by stimulating by some eye openers, a reminder, play quiz test, and refresher, real world practice, and I show my treatment algorithm, and finally I finish here. So by telling that in teaching, the greatest sin is to be boring. Hopefully I didn't bore you, so thank you very much. So question will be, I think, later. Yeah.
Right, thank you, Amal Lal, for your nice cases, challenging as usual. And now we will actually have the next case presentation by Dr. Hassan Ghazal. He is a consultant hematologist at King's College Hospital in Dubai. And Hassan, actually, he is one of the very knowledgeable persons here in Dubai. And he actually was challenged very soon after arriving in Dubai with this very interesting case, I think, that he is going to present. And he was not given time to settle down, you know. The challenge was given to him straight away. He's a consultant clinical hematologist and medical oncologist, as I said, at King's College Hospital. Hassan, please welcome.
Good evening. Thank you all for inviting me to give back my case here and learning experience. As Dr. Marachi mentioned, I spent 28 years in the US and came back to my home, came back to Lebanon for 2 or 3 years, and then to Dubai about a little over a year ago. So we'll see what happened here. So I'm going to present, we have talked about pregnancy-associated acquired hemophilia. It's really a whole chapter in acquired hemophilia because it's unique and different than other types of acquired hemophilia. And again, the importance point here is to recognize the disease early on because it can lead to catastrophe if we don't diagnose it correctly. As you can see from my case, actually, is a perfect example. So usually it appears, as mentioned already, after the first pregnancy, so almost 3/4 are primies, and again occur about 2 to 5 months after delivery, and may persist for 1 year postpartum. So we have some Italian registry, and again, the median time to occur is about 2 months from delivery to the onset of symptoms, identification and diagnosis. Again, in other series, median time, 90 days from delivery to the diagnosis. So the good thing about this, that during pregnancy, it rarely becomes symptomatic. So at least some reassurance for the woman that it rarely causes problems such as miscarriages or hemorrhage during pregnancy. And again, we can detect antepartum inhibitors in about 17% in the EEC2 series. As mentioned, 2.5 months was the average time postpartum, and 25% occurred between 4 to 10 months after delivery. And back to what Dr. Lal was saying, a good history, because this disease can present even months and months after, because the antibody can persist. The good news in this type of acquired hemophilia that it can disappear spontaneously without treatment in a good range of cases, 76% at least from this series, after 30 days. So there is spontaneous recovery. So not every woman needs necessarily to be treated with the immune drugs or immunosuppressive drugs. Occasionally, it can persist long enough to complicate subsequent pregnancy. If the woman gets pregnant, right after with her second one, it can certainly complicate things. And again, usually the antibody inhibitors do not persist with the next pregnancy, as Dr. Paul mentioned earlier, that about 20% is the risk for the next pregnancy to have problems. Again, good news for peripartum here that if you look at mortality rate, it's the lowest in the peripartum group here, 26 cases. And of course, it's the highest in underlying malignancy cases. So if you have underlying malignancy, again, whether it's due to the malignant condition or what have you, the mortality rate can be up to near 50% in those cases. And in the autoimmune, in between 26%, and in the idiopathic, which is the most common. So again, we cannot many times identify an underlying etiology we call it idiopathic, the mortality rate around 20%, so 1 in 5. And I bet you many of these mortalities could have been prevented if diagnosis is made early on. So it's critical to make the diagnosis early on before any catastrophe happen. So let's talk about more data here. 42 patients with peripartum acquired hemophilia, and you can see the inhibitor titer can range from really very low titer to very high titer, but the average is 7.8, so not usually in a very high category. Antibody inhibitor can be found in few patients, and the first-line treatment is successful in the majority of cases. So many of these resolve in over 80 to 90%. Complete remission is achieved in, again, 3/4 of these patients with first-line immunosuppressive therapy. And sometimes we could see postnatal bleeding through the transplacental transfer of the antibody, but it's, again, rare. Importantly, what's the time to negative inhibitor in pregnancy? You can see the curve on top is the pregnancy, and the blue one is the non-pregnancy associated. And they follow almost the same course, but you can see it can persist over 6 months sometimes, but to a lower degree. And most of these cases are resolved by 1 year. Again, no death in pregnancy group in this series. So the key conclusion, pregnancy-related acquired hemophilia A is rare. I didn't mention it, but it's about 1 in 350,000 pregnancies. So you can see it's only 3 per million almost. So it's not obviously a very common thing you think of. And optimal treatment, as everybody has mentioned already, bypassing agents, either activated 7 or activated prothrombin complex. Time to negative inhibitor in pregnancy-associated AH is similar to the non-pregnancy, as we have seen from the previous curves. Okay, now to my case. So this was it was my first month starting to practice. And, I am labeled as hematologist and oncologist, so everybody was calling me for heme problem more than cancer cases in the beginning. But anyway, when the ER call hematologist, that means there is something serious. Usually we don't get called often to emergency department. So this was an Egyptian lady, 38 years old at the time, delivered the baby via C-section in January 2021. That's when I start my practice here in Dubai. So her postpartum period was really uneventful. However, talking to her obstetrician, who, by the way, never heard of acquired factor VIII in pregnancy or postpartum, the only thing she was telling me that she had a bruise area along her surgical site from the C-section, while on prophylactic low molecular weight heparin with enoxaparin, that was stopped after 5 days because of that larger medium bruise area that was little unusual according to the obstetrician. So she went home. Obviously, she was breastfeeding the baby, who was a girl, by the way, baby girl. So she presented 4 weeks later with painful swelling of her right leg, almost double size than the left leg. What's peculiar about this was multiple bruise areas in her leg all the way to the ankles. So you could actually see some bruising all the way to the ankles. So in the workup in the emergency department, INR was normal. The PTT was 60-second, which may or may not raise eyebrows, D-dimer, they did D-dimer 1.86. Everybody get D-dimer now in emergency room. Especially they were suspecting deep vein thrombosis, being postpartum, etc., and swelling and pain in the leg. Fibrinogen was normal, von Willebrand factor 135%. Of course, these tests were not ordered by emergency room doctor. I did the workup, so we can see the data here. Hemoglobin was 10.5. So the initial thinking in the emergency department that this was a possible DVT post C-section, possible maybe lupus anticoagulant when the doctor called me that, well, there is some slight elevation in PTT, maybe she has lupus anticoagulant, and postpartum now she has a DVT. So when he told me about the situation on the leg, I had to come, and it was, you know, if I recall, on a Friday as well. So, by the way, the rest of the lab platelets also were normal. So with the increased bruise, we suspected that this is not a straightforward blood clot. They were actually ready to start heparin as an anticoagulant. And I just didn't like the way her leg looked like. It didn't look to me like a typical DVT. Now, Doppler scan, luckily, was negative. They didn't see shadows like the other case where they gave streptokinase. Now, here is the trick, as Dr. Marashi said. All I knew about labs here, we have our hospital lab, which doesn't know what a mixing study used to be. Now they are doing it after I told them we need to do that. And they had no idea where to send. Usually they send to reference lab in UAE. And unfortunately, which I realized later, reference lab does not communicate very well with other labs in Dubai even. So the story I got that, only in Abu Dhabi that they do factor 8 or factor 8 inhibitor. And after they checked and checked, they ended up sending the specimen all the way to the US, to LabCorp in North Carolina, to do the Bethesda titer and the factor 8 inhibitor level. So how do we treat the patient who is in front of us? All we have is a PTT of 60 seconds and maybe just a bleed in her leg. Not exactly compartment syndrome, but certainly about to become compartment syndrome, perhaps. So knowing the situation, we decided to treat her as empirically, really, as a factor 8, acquired factor 8 postpartum, and treat her empirically, especially the next morning, as you can see later. These data, by the way, came 2 weeks later, less than 1% factor 8, and 14 Bethesda unit came back from LabCorp in USA. We did a pelvic ultrasound because she was actually still bleeding also vaginally, and there was a rather large hematoma on the right side, on the side of the swelling in her leg, about 8 by 6 centimeter. And at that point, you know, her PTT the next morning was over 120. So there was no gimmicks anymore. This is real, you know, over 120 is something big. So we sent, of course, initially mixing studies, which luckily, finally, we were told the American hospital can do it. So actually, we sent a specimen locally to the American hospital to do our mixing study, which obviously did not correct. So we treated her with activated 7 in view of the pain and swelling in her leg. And quickly she got better. In fact, the next day she wanted to go home. I feel fine. I need to breastfeed the baby, etc. So this is the situation we're facing. So we kind of debated whether to immediately started any corticosteroids or not. So after 2 or 3 days, she had persistent PTT over 120, and there was question mark, started to have more swelling in the opposite leg. So, you know, we said, this is it, let's start prednisone. Again, lactating woman, you don't want to give any alkylating agents or try to avoid any other immunosuppressive agent. So we thought prednisone 60 would be probably enough to start with. So it was started actually 2 weeks later, because clinically she was doing better after the factor 7A administration. So 2 weeks later, she has improvement, great improvement in her leg. The pelvic ultrasound showed resolving hematoma. Repeat PTT 1 week after prednisone showed a decreased level to 50 seconds. Remember, it was over 120. And then we tapered steroids slowly over 6 weeks period of time. And we followed PTT here because we couldn't get factor 8 frequently. Of course, after talking to Dr. Marashi, I realized many labs locally can do factor 8. You know, the problem is there is no contract between hospitals. So the reason I get, or why that we cannot send to Rashid or other hospitals, we don't have contract. You know, we have to send to reference lab. And it's amazing to me, reference lab doesn't really know which lab can do this test locally, and they ship it all the way to the US. So certainly communication system here was not very good to me, and this was one of my first really cases in general, even in the UAE. So in June, which is about 4 months after the episode, 2 months after we stopped the corticosteroids, she was completely asymptomatic. PTT, by the way, was more like 30 seconds in the normal range. Factor VIII was still low. We did the factor VIII level, and it came back at 12% only, but she has absolutely no bleeding. So back to when we give or we replace factors, it's really clinically, if the patient is fine and not bleeding, you don't necessarily need to replace. And in August, we had another factor VIII, and we saw it up to 26% of corticosteroid. Of course, here about 5 months after we stopped the corticosteroid. Of course, no further bleeding. And just 2 weeks ago, she was in my office. We did another PTT. This was her lowest ever, 24-second. And factor VIII finally reached 76%. And this is almost 1 year since her diagnosis. So she's not interested in further pregnancies. Obviously, she has another son, and her daughter is doing very well. She never had any problems. So again, happy ending, but again, as Dr. Lal has mentioned, early diagnosis, early thinking of coagulation disorder, early recognition of postpartum acquired factor VIII, even though it's so rare, but when you face the case, if you don't diagnose and treat accordingly, it can lead to catastrophic outcomes, certainly, especially if we were going to treat her as a DVT with heparin or anticoagulation. And again, improving our testing capability, I would say also communication among labs here is crucial, I think, because obviously everything is available here. And even the reference lab did not know that for some reason. Anyway, so thank you, and I'm glad I was invited for this. I guess panel questions or whatever. Thank you.
Yeah, I think we'll have a panel discussion here. Thank you, Dr. Hassan, for very nice case presentation, and actually to be aware always that this is a disease that can happen, and when you keep your eyes open, maybe you may not miss, and then you may be able to save the patient from catastrophe, as was said. And one more thing is that Hassan was new and he didn't know a lot of tests actually are done because the government hospital is central and they have a lot of tests. We do send, but the problem is that there is no contract between the private and the government hospital. So from city, we send a lot of tests to the government still, because I work partly for the government, so we have that connection. But they have to send with cash. So there is no, so we have a petty cash which we send. Sometimes the money can be a lot. For example, you want MRD flow, it's 6,000 dirhams, so they have to take the person sending the sample has to take that much money, and if it is more than one test, so more money. But a lot of things are done in the government and also done at a very high level of efficiency, and so you don't need to send. For example, your BCR, ABL, if you send abroad, you get degeneration of the sample and you get a lower result than it should be. So here we do it in the same, within an hour it reaches the central lab. So many things are done, so just for information. So this is out of the thing. So I welcome our panel to come up here, and we have questions. We need microphones as well, yeah. Please welcome Professor John Grant, Hassan, and Amar Lal. Anybody has questions, can please. We need more than one, right? It's okay, one we can manage.
Unless they need to ask questions.
Well, first, I'd like to thank the staff for the excellent presentation. This is very interesting. It comes with, in good time, I just got a case 2 weeks ago. I worked at Al-Zahra Hospital and at King's Hospital with Dr. Hassan. So I got a 60-year-old guy with history of laryngeal cancer, treated a year ago with chemoradiation. Then he was recently admitted to our hospital for sepsis, and he has what looks like possible recurrence of his laryngeal cancer. His PTT when he was admitted was above 100, and he was really bleeding from the upper airways. So ENT was consulted, of course, to see him, and he wants to do tracheotomy, but because of the PTT elevated and the risk of bleeding, he said he won't touch it unless his PTT is below 40. Patient was in ICU. They intubated him, and they called me because to see what's going on. They suspected possible antiphospholipid antibody. They want to start him on anticoagulation. So when I saw him with this picture, of course, I asked him to stop the anticoagulation. We did the mixing study, and of course, it was not correcting, suspecting definitely that he has acquired hemophilia. The factor VIII was about 3%, and we sent for Bethesda, it was about 15 or 16. So based on that, I mean, we established the diagnosis of acquired hemophilia, and now we are, of course, requesting to use factor VII as a bypassing way to do his procedure. And while waiting, we were debating about starting on, he was started on steroid, of course. We started maybe 1 dose or 2 doses of rituximab while waiting to approve his medications, and low dose of cyclophosphamide. We don't have oral cyclophosphamide here, but we use it very low dose IV, 100 milligram daily of cyclophosphamide. But for now, everything was put on hold because recently he got more sepsis, and we have to stop everything, and treated his sepsis with antibiotics, and we give him also, he got filgrastim, things like that, and he started to recover. His PTT recently dropped to about 50, 60, but still without any major oozing. So we are at that point to do the procedure for him using factor VII, of course, as a bypassing way, and like you mentioned before. So what's your advice for this case?
Well, a very interesting case, and I would dissect it by saying the evidence you present is certainly consistent with acquired haemophilia. Let me say right at the outset, if there was a clinical urgency to do a tracheostomy despite the prolonged APTT, clearly you could do it with Novo-7 alone. I mean, you don't need to postpone the surgery because of that. But I think the approach which you've adopted is the sensible one of it's not urgent at the moment, try and suppress the inhibitor with rituximab and or steroids. That's what I would do. So I think you're doing the right thing, not rushing into it, basically.
Yes, so mainly the patient has been on ventilator now for more than 2 weeks, and of course, as per the ICU, patient can get more problems with persistent intubation, including they might have fistula, they might have more infections. They want to try to extubate him as soon as possible, do tracheotomy, do some biopsies from that new lymph nodes, and try to extubate him. That's what the dilemma was. They want to speed the process of doing the procedure to extubate him, and of course, as like you said, as the second part will be eradication of the antibodies later. That was with our plan now, just to do that.
Clearly by giving rituximab and or steroids, the problem of infection is going to be made worse. So perhaps it's a decision you're going to have to make. We don't know the patient, but the fact is you can do a tracheostomy with Novo-7 in the presence of a prolonged APTT, but you're going to be committed to at least 10 days of therapy. It's not going to be cheap.
Yeah. Well, the issue also was to convince the ENT doctor, because our surgeon, many occasions he said he wouldn't touch him, but I have to meet with him personally with our group to explain, no, if we give him factor VII, the patient should be able to do it safely without any risk of bleeding. So that was another issue with the surgeon himself, who was not first was not accepting to do the procedure without having a normal PTT. We explained normal PTT might take weeks, like you said, at least 6 weeks maybe or more to correct. You have to eradicate the antibody and get factor VIII elevated, and this is not something, yani, for now it will happen, but it will take time.
No, I understand the problem. I mean, that's a problem I've encountered many times with surgeons naturally reluctant to take a patient on who they think is at particular risk. And they are, let's face it, the people taking the risk, the surgeons, so I understand them. But what I'm saying to you very clearly is you can show published protocols and case reports of Novo 7 being used to control the bleeding, but it is going to be expensive. You're going to be using Novo 7 2-hourly for the first 48 hours and then winding down to probably 4 days, 4-hourly after that. But you're going to be using about 10 days of therapy, even for a fairly straightforward procedure such as a tracheostomy, and that's going to be very expensive. So my preferred option really would be to try and defer using something like the protocol you're using, steroids and rituximab. Some people have used cyclosporin, which is another alternative, which has been used successfully. But I think I would adopt the conservative approach, to be honest.
Can I follow up a question to you, Prof? In case of an emergency situation like that, would a plasma exchange help in the acute phase?
The answer to that, regrettably, is definitely no, and we address that in the guidelines. The problem is you get a temporary dip in the level, but there is so much antibody in the extravascular fluid that as soon as you take the patient off, that you've done the plasma exchange, it shoots up again. So it's of no lasting benefit. Sadly, it would be a good strategy. And people in the past have used intravenous immunoglobulin as well in these circumstances, but now we don't recommend it.
So, Professor Paul, the case which was presented by him is almost same case which we had. You know, usually in middle age, they present with the retropharyngeal swelling. This is common presentation of acquired hemophilia. So this patient will also bleeding, swelling, as I mentioned. So we used also factor VII too early, and 6 or 7 dose bleeding stop. Even that patient also needs tracheostomy. So we did it everything. So it's, it takes 1 or 2 days actually bleeding stop, and with the support of factor VII, if procedure is needed, we can use it. We did similar case, by the way, and as I mentioned, in that patient, we used very quickly our cube, which I mentioned, roids, rituximab, and this was the thing that we wanted to early response. We add rituximab on day 3. So.
Yeah, the other thing I would add in cases like tracheostomy and retropharyngeal, to add in tranexamic acid as well, which although there's no clinical trial, the impression is that it definitely enhances the efficacy. Whereas I try to avoid tranexamic acid together with FIBA because it's a prothrombotic agent, but tranexamic acid. But it works well in the setting of surgery, but it's expensive and you have to give it by regular bolus injections, and it's not easy to do that on a 2-hourly basis.
Thank you. Actually, I have 2 short practical comments and 1 question. The practical comments is ignoring abnormal APTT prior to surgery actually can lead to catastrophe. Second one is the bypassing agent, especially activated factor VII. Sometimes it's saving lives in some situation, but it is not a magic solution for any abnormal coagulopathy or any bleeding, and sometimes we ended up with thrombosis and clots. So there is trend here actually to use Novo 7 for any bleeding or any coagulopathy, but this is what we have seen in our practice. My question is about acquired factor VII and mixing study with prothrombin time. So we've seen some cases. So the patient has prolonged INR, isolated prolonged INR, low factor VII, and mixing study for prothrombin is prolonged, and ended up with some inhibitors. Any comments about validation of this mixing study for PT rather than APTT? I would be thankful.
There are two important questions there. Let's deal with the first one, which was about using Novo 7 off-label. And I agree with you that it's been overused, usually in situations of desperation. And, this was a trend. There was a trend to use it in trauma, actually. And many of you will remember there was a study published from South Africa in the end, which showed very clearly that it did not work in the setting of trauma, and it included all sorts of injuries from stabbings to bullet wounds. That was the first one. The second one where it was used was intracranial hemorrhage or stroke. And again, there was a good publication in the New England Journal of Medicine, which again showed no benefit. Where the situation, I think, is a little bit unclear, or at least it's changing, is postpartum hemorrhage. And many hospitals, including my own in Oxford, do allow the use of Novo 7 in the emergency setting of postpartum hemorrhage, but really as a last resort. And I know that Novo Nordisk is seeking an extension of the license based on clinical trial evidence to get Novo 7 approved for the treatment of postpartum hemorrhage. But I think we need to be evidence-based, and to answer your question, it shouldn't be used in the setting of trauma, shouldn't be used in the setting of intracranial hemorrhage. But I think it does seem to have a role in postpartum hemorrhage, and that decision is with the licensing authority. But it should be used really as a last resort, not up front, not before we use blood and whatever. Okay, let's talk about factor 7. Factor 7 deficiency is, the congenital form is the commonest of the rare disorders, with an incidence of about 1 in 500,000. But actually, there are two things to say. The first is you need very little factor 7. You need only about a level of 20% for effective hemostasis in the setting of surgery. So you can have a prolonged prothrombin time and have a factor 7 level of 20%, and I would be very happy to go ahead and do surgery. The commonest cause of factor 7 deficiency is actually vitamin K deficiency, and that happens very quickly in people in hospital because most of the vitamin K it's not stored in the body, it comes from our diet. And if you put someone in hospital, they're not eating, they're on broad-spectrum antibiotics that kill off the gut bacteria that make vitamin K, you can rapidly get... There are several studies, including one we published from Oxford, showing vitamin K deficiency. And because of the short half-life of factor 7, it's the first factor to go down in vitamin K deficiency. Antibody is very low, the incidence of, even if you take factor 7 congenital deficiency and you treat them with Novo 7, the incidence of inhibitors, those in the international registry, was 2.6%. But even then, if you take someone with factor 7 and antibodies and you treat them with Novo 7, they still respond clinically. You may have to slightly increase the dose, but it's nowhere near as problematic as hemophilia A with factor VIII inhibitors. So the method you're talking about, is it validated? Yes, of course you can do mixing studies based on the prothrombin time for factor 7 deficiency. But true inhibitor development in factor 7 deficiency is very, very rare. I'm sorry, it's a long answer, but I hope that helps.
You have to question the diagnosis, I think.
Yes,
with that.
that's what I'm
It's
trying
not,
to say.
this is a zebra, we call it.
Can I add something to the factor 7? What we have, the phenotype that we have in some of the families here is that of a non-bleeding phenotype. And they have very low factor 7, less than 10%, 5%, but they don't have bleeding and they have undergone surgery. Is it this factor 7 carried by the platelet, or is it some other way of explaining this non-bleeding phenotype?
It's a very valid observation, and it's well known that factor 7 has various unusual features. It is the commonest of the rare congenital disorders. It's the only one associated with prolongation of the factor of the prothrombin time. But the variability you talk about is absolutely true, that sometimes people have a low level and no bleeding problems. Sometimes they have modest bleeding, modest deficiency, but severe bleeding. And it must be related somehow to the genetics, but I don't understand it. But it's a very true observation that. A bit like Glanzmann's thrombocythemia, actually, where, again, some people have serious bleeding problems, others virtually normal.
And they go in family, the same family, they are all the same phenotype. There's no difference between them.
I think it must be
Genetics.
some genetic. It's very different from haemophilia. You know, when you were presenting the classification of haemophilia by the factor level, we know someone with a level of 2%, as you said, is moderately severe, and they'll always be moderately severe. But it's not true of factor 7 deficiency.
So last 2 weeks, by chance, we have 3 patients, factor 7 deficiency. One was admitted for induced labor. Other was after 2 days, one ruptured membrane, again labor. And third was cesarean section, by chance. So I tell you, very interesting thing. In all of 3, I went through the history. They have dental extraction and so many things. Despite of level was between 1 to 5, very low. They have never bleed. Now the problem is, if I don't give, anything happen, I will be in trouble. So I have to give even before labor. So I started to, very low dose, 20 mcg per kilo, and then check the INR, make it 4 hourly, then very quickly 6 hourly. I have to give to cover myself. Although I was confident that patient may not bleed, but I have to do. Sometimes
I would entirely agree with you, and certainly in Britain, I'm sure far more than here, and your experience must have been in the US, medical legal and litigation drives the practice. And the trouble is with all these guidelines, you have to go with the guidelines. Yes. And if someone says you have to have a level of 20% of the setting, so you can't use your clinical discretion, because if something goes wrong, you will get sued.
True.
And you must have had this in the US. This fear driving guidelines can be a problem sometimes.
Actually, a lot of lawsuits on acquired hemophilia patients because frequently not diagnosed early on and lead to catastrophe. Lawsuit is attached to that. I wanted to ask you, so with the use of the new oral anticoagulants, if you have a hemorrhage, we have seen some data on activated 7 in using DOACs. What do you think about these?
Yes, I think there's convincing evidence for both Novus, and of course there are now direct factor 10A antagonists. So let's
we don't have
right, but so there are the direct antagonists which are used. But you're right. If you don't have those, I think there's evidence for both FIBA actually and Novus 7 to use them. Absolutely.
So if somebody on Xarelto, we're talking about
under
the newer,
Vicatran and we use exactly all of these. Yeah, and also and we use DOAC stop in the laboratory because just as with APTTs being prolonged because of heparin, it can cause a problem with the assays. So there's a little tablet you can put in the blood called DOAC stop, which we use, and it absorbs the DOACs out. And but in the absence of specific antagonists,
you can use
FIBA or Novus 7, but off-label.
Right.
Yeah, for the Vigatran, we have locally available iduricizumab. That's not so expensive, but unfortunately the andexanet is crazy price, $40,000 for 1 dose of reversal. So nobody actually keeps it in the hospital because the price is so crazy. Who will buy that? And you just imagine, you are pushing one Mercedes for 1 second into the patient to
and you may
correct
never have
a
a
DOAC,
patient,
and the patient may not even bleed.
Right.
So this is the thing with the 10A inhibitors.
Yes. Yeah, I agree. I mean, let's face it, they're not cheap products. That's absolutely true. And we need more, so there's competition. And
Now this I'm talking about andexanet.
yes, of course you are. No, yes, yeah, sure.
I have a question.
Yes.
So my question in acquired hemophilia compared with congenital hemophilia, when you come to eradication of the antibodies, in acquired hemophilia, like you said, you use prednisolone with rituximab and cyclophosphamide, and you don't use factor 8. But in congenital hemophilia with antibodies, if you have congenital hemophilia, some people build antibodies after years. I think they do use factor 8 when they do eradication. What's the behind that? Yeah, what's the science behind that?
It's very much a changing field in congenital hemophilia, but you're right, immune tolerance is used in congenital hemophilia A with inhibitors. And you can use a high dose or you can use a low dose. But my honest opinion is it's better to use the high dose, because if you use the low dose, there are 2 problems. The first is it takes longer to get rid of the antibody, so you're just using a low dose for much longer than you would be using a high dose for a short period. The second problem is that you get breakthrough bleeds much more frequently with the low dose than with the high dose, which is why the international trial of high dose versus low dose in a randomized study was stopped. But what is changing is the introduction of emicizumab, and emicizumab is a monoclonal antibody which the hematologists here will be very familiar with, and that is now becoming the standard for patients with inhibitors. In fact, people don't, in many cases, do immune tolerance anymore. If someone develops an antibody, put them on emicizumab because it's given subcutaneously once a week, maybe up to once a month, actually, in some cases. I can tell you in the UK, 60%, the current figure is 60% of patients with hemophilia A and antibodies are on emicizumab. It doesn't work in hemophilia B, by the way. But the point is, immune tolerance takes a long time, so we don't use immune tolerance in acquired hemophilia, because the steroids normally get rid of it in about 6 weeks' time. Having said that, there are some people who have used immune tolerance, actually, and Laszlo Nemes in Hungary is somebody who's published a lot in this field, but we don't tend to use it. And equally, in congenital hemophilia, steroids don't work at all, so steroids are of no benefit in eradicating the inhibitor. Does that answer your question? It's a long answer, but I hope it's helpful.
Thank you very much. I deal only with pregnant ladies. I'm an obstetric medicine physician, and I run an obstetric
Can you
combined.
keep the microphone next to your mouth?
I run an obstetric hematology clinic with my colleagues here, Dr. Husni and his colleagues. When we have a prolonged ABTT, as I told you before, the first thing we think, of course, of ABS and antiphospholipid syndrome. We do the mixing test and we take it from there. And I take my advice of my hematologist. It is very rare that we find an acquired hemophilia, but we do the protocol, and as you said, the first pregnancy is usually safe, but the second and third pregnancies, that's where troubles come to appear. The other thing is that about Novo-7 in postpartum hemorrhage, and as I told you outside, that is our obstetricians and anesthesists are very, very reluctant to use it in postpartum hemorrhage. And if at all, then they have to use their thromboelastogram, which they think that is validated for them, and without being sure that they have enough platelets on board, they don't use it.
Can I answer? There are two points there. The first is about the lupus anticoagulant, and you're right. That's far commoner than acquired hemophilia, and even commoner than lupus anticoagulant heparin contamination. So I would reinforce to the hematologists here what I said in my talk, and that is if you do a chromogenic assay for the factor VIII, that is on a machine using a chromogenic assay rather than a one-stage assay, that is insensitive to the presence of either heparin or lupus anticoagulant, so you get rid of the problem. So if you've got automated machines, my strong recommendation is go with the chromogenic assays. And actually, the chromogenic assays are becoming more widely used anyway, because when we use the extended half-life factor VIII and factor IX products, many of which are pegylated or altered in some other way, the only reliable way to assay them is with the chromogenic assays. So that's the first one. The second one, you're right, we need the results of hard clinical trials to guide us not only on the efficacy, but the safety of Novo-7 in the setting of surgery, and to take account of all the other confounding factors and other medication that's given, such as tranexamic acid as well. All I can say is that's in the hands of the licensing regulators, at least in Europe at the moment. The EMA is looking at this, so we will go with whatever they say. But at the moment, it is not licensed, and we only allow the use of Novo-7 in the setting of postpartum hemorrhage as a last resort, after all the conventional therapies, when there's a real risk of death, and the case has to be discussed with a hematologist. You can't just order it from the pharmacy.
Yeah, I can agree more. I think the number, especially patient in the hospital or ICU, make sure they drew the blood from peripheral lines. Contamination by far, 1, 2, 3, 4 is contamination with heparin before you conclude this is an acquired inhibitor. I wanted to ask you that we've seen some data on factor 11 has been neglected for a while. It seems like there's come back to try to use it as a therapeutic option as well, with the theory that factor 11 is important to generate that big initial sort of thrombin surge that can improve on the coagulation system. Anything going on in research?
I must confess I'm not aware of any research in that area, but it sounds entirely plausible, and certainly when we give fresh frozen plasma, it's a plentiful supply of factor 11. But certainly factor 11 in the coagulation cascade is very important. It participates in a feedback loop, and in activation, once it's been activated, it feeds back and generates more thrombin generation. So I think it's plausible.
That was the idea. No, there was an abstract presented.
Yes,
that's why I
so
was
factor
asking.
11 is certainly very important. The problem with factor 11 is you can give too much of it, and definitely too much factor 11 is thrombogenic. So if you've got someone with factor 11 deficiency, it's very important not to overtreat them, to monitor the level, because there are many cases of thromboembolism that have been reported. So it sounds plausible, but I wouldn't overdo it.
I have one other point. When we always talk about mixing studies, unfortunately, it's not always black and white. So many times you see partial correction or just 10 seconds less, 20 seconds less. Does that correlate with the degree of inhibitor perhaps, or just they didn't incubate the specimen correctly? Because, even with inhibitor, even my page I didn't mention, but they tell you there is some correction with the mixing. But at what point would you say it's positive or negative test?
Well, I mean, traditionally it should be 50% correction, but I entirely agree with you. Sometimes I'm afraid it is that grey zone, which is a terrible dilemma. But I agree with you. It sounds so simple. It isn't always that simple. I think when the inhibitor theta is high, it clearly is much easier. And it tends to be the grey zone when the antibody level is much lower, which is entirely predictable and understandable. But I agree with you.
Just a word of caution that you're not going to get black and white.
Absolutely.
In the same scenario of patient had acquired hemophilia, bleeding, and we start treatment with factor 7. In the real practice, until which time you give him by hourly treatment, just until we stop the bleeding or even more?
So it depends on the severity of the bleed, but generally speaking, one dose will not be enough. There have been two studies which suggest that you need at least 2 or 3 doses. Actually, in both studies, 2.2 is the average dose given. So let's say 2 or 3. The problem is that there is no validated test. I say no validated test because colleagues rightly talked about people doing thromboelastography or thrombin generation tests, but they're not validated by the ISTH yet, and there are various ways you can do it: whole blood, platelet deficient or platelet-rich plasma. And it's really your clinical skill that determines that. But I would say for an average bleed, bank on giving 2 doses separated by 2 hours. If it's a particularly bad bleed, let's say a muscle bleed, then you're probably going to need to prolong that 3 or 4. It's an art rather than a science, and I can't give you an answer other than to say that 1 dose is very unlikely to be enough for even a straightforward bleed because of the short half-life. It has a short half-life, as you know, of between, well, certainly 3 hours at the most, 2.5 hours.
Any question? Yeah.
Assalamu alaikum. Khalid Habibi, Hemophilia Nurse. Thank you so much for your presentation. I believe all of you highlight the important points. It's not a question, it's more just re-highlight the importance of having the mixing study. This is for sure going to help you to have early diagnosis and early intervention and improve the outcome. I believe the first challenge you face, Dr. Hassan, is the availability of having the mixed study. So imagine this is well-established hospital. What's the scenario in remote areas? I believe we need to do something locally here, and I believe Dr. Barashi, through the Emirates Hematology Society, have all the connections. So this is one of recommendation outcome of this meeting, to have a better communication among all the hematologists and facilities in the UAE.
No, I can't agree more, and that's why I raised the problem, because even now that we know some labs are doing it, we can't even send to them, like Dr. Marashi said, because we've sent, exactly, we have sent the patient one time physically to do the test. First thing they told her, we don't accept orders from non-physician in the hospital, so that's another problem. You can't come with an order, I want to do factor 8. So she had to see a physician, so she gave up the idea and came back to me.
Yeah, but they can tell laboratory can send to laboratory without having the hospital. For example, City Hospital from our
We
lab,
asked them,
we can
they-
send to the lab of Rashid or Dubai Hospital. We send it and they pay money to the lab. That doesn't need to go
Right.
to a hospital. But if the patient goes himself, they don't know.
Right,
They
the
will not
hospital
take-
was not willing to do that
Of course,
either,
they will
that's a
not
problem.
take, because the patient
Like
say, I
this-
want to do this test. They will not do. There should be an order in the system. So when the sample come from another hospital, there is somebody there, they put it as an order in the system, and then it gets processed.
Yes.
So how could you change the system, which is, I would ask, I don't know, I mean, I'll have to ask
I
you.
think the
How-
system
what
can
would-
be changed if there's an agreement between hospital and hospital, especially their contract. And the contract has not been done. And maybe they are not very keen to do, because they have got their own, they send it abroad mostly. So this is, but we do, because we send a lot of samples to the government hospital for flow cytometry, fish studies, cytogenetics, as well as these other factor estimation. So we send to the government because we get a quick answer. So we send, and we have got money reserved.
Right, in
for
your
this
case,
one.
it's easy, of
So
course.
for us, so you need, your hospital has to communicate
luck.
with the other hospital, then it can be done. Because the administrations are different,
Yes.
and the money, of course, is involved these days. So finances, they have to answer to everybody. So
Yeah, I mean, imagine you have an emergency case and you have to treat, and 2 weeks before you know the results. So you have to treat the patient. If you're, based on my clinical suspicion, I had to treat the patient, because I realized we're not going to have a level in 24 or 48 hours even. And I was right. It was 2 weeks later when we got the factor 8.
right, I think.
All right, I think we're too late.
Yeah, okay. So thank you very much. Actually, we thank you, all of you, for participating in asking questions and making it very interesting. I thank
Yes,
Professor
I'm
Paul
impressed, actually,
Giangrande
but thank
for
you
his
for being here.
fantastic presentations, and also for actually answering most of the questions, and also for
he's the
Dr.
expert
Hassan
one.
and Dr. Amar Lal for their very nice presentation, for all of you. And also I wish to thank Novo for arranging this meeting and running it very smoothly, and for their very full support. Thank you, and I think there is some dinner, I think, at the moment. Yeah.
By the way,
So doctor's dinner will be in Le Cuisine Restaurant on the second floor.
I tell you, this
Thank you.
was my first week in practice.